Hi everyone, we'll just get started in a second, just waiting for a few more people to join this evening. Perfect, so I think we'll get started. So good evening everyone and welcome to another CPD accredited webinar by Plant-Based Health Professionals UK. For those of you who don't know me, my name is Rahini Bajekal and I'm a nutritionist and communications lead at Plant-Based Health Professionals UK. This evening, to mark International Women's Day, we have the wonderful Dr. Hannah Short, who's going to be speaking on premature ovarian insufficiency, otherwise known as POI, and early menopause, a lifestyle medicine approach. Hannah has spoken previously on our webinars on a variety of topics, and she's also going to be discussing her fantastic book, The Complete Guide to POI and Early Menopause, which she co-authored with another doctor. But before we get started, I also want to let you know about the next webinar we have coming up in April by popular demand, which is plant-based diets and bone health. This is such a hot topic, and Dr. Matthew Nagra is such an expert in this area, and I urge everyone to come along and educate themselves about how we can maximize our diet and lifestyle as vegans for bone health. It's going to have lots of practical takeaways as well. So do share that. The link is up on our website at pbhp.uk/webinars. So do share that widely, especially with health professionals who are looking after patients who might be plant-based or vegan themselves, or other people who are interested in this topic. I'd also like to thank our sponsors, including veganfitness.com, who kindly lent us their Zoom platform, and the BSLM, who give us CPD accreditation for this webinar, and ACLM, as this webinar is also eligible for CME accreditation, and you'll receive the certificate in a few days' time in your inbox. Plant-Based Health Professionals UK is a community interest group dedicated to promoting the health benefits of a sustainable and healthy whole food plant-based diet. The best way to support us is by joining us as a member. This is open to everyone around the world, and we have student memberships, general public memberships, memberships for health professionals, and a very active Facebook group where you can get involved. And you can also subscribe to our newsletters and donate if you enjoyed this webinar and found it useful via pbhp.uk/donate. And also consider following us on social media on Facebook, Instagram, and Twitter. So now I'm going to hand over to Hannah Short to kick off the presentation for the evening. Hannah is a GP specialist in menopause, POI, and premenstrual disorders, and I'm going to hand over to her so that we have time for a live Q&A at the end. If you save all your questions for Hannah and pop them in the Q&A box at the bottom of the screen so that we can have a great discussion. Okay, wonderful. Over to you, Hannah, and thank you.
Thank you, Rahini. I'll just share my slides. Okay, so yes, thank you. Happy International Women's Day, everyone, and thank you to Plant-Based Health Professionals for asking me to talk. So today I'll be talking about POI and early menopause and how a lifestyle medicine approach can support kind of management of these conditions. These are just my declarations. And this is just an overview of what we'll be discussing tonight. It will be a real whistle-stop tour because this is such a huge topic. Could probably spend hours or even have a whole day of study dedicated to it. But it's an often overlooked topic. So I want to kind of just start with the basics. Then we'll go through everything you can kind of see here. So the pillars of lifestyle medicine. And then at the end, we'll talk with Rahini. I can answer your questions and discuss further things as necessary. I have to, please forgive me if I have to take sips of water or stop to cough. I've just got quite a bad cough at the moment. I'm hoping it's not going to prevent me presenting the whole way through. So just please forgive me if that interrupts anything. Okay, so a lot of you will be aware that menopause is a bit of a hot topic at the moment. Which is much needed because at least half the population will go through menopause if they live long enough. It's going to affect any woman or anyone born with ovaries at some point in their life and is a natural transition for most. However, what's often missing from this conversation are those people who are affected below the age of 45. So any age over 45, if you experience menopause, which is technically said to be 12 months after your final menstrual period, that's considered normal, although the average age is 51 in the UK. Anybody below the age of 45 is considered to have had an early or premature menopause, and this is often missed out. So, and it deserves kind of a discussion on its own merits, because although a lot of the challenges are the same, there are some particularly specific challenges, particularly relating to self-identity, issues around fertility and the long-term health impact. Coupled with that are the iatrogenic causes, which can lead to early menopause and POI. So for those of you who aren't medical, iatrogenic means medically or surgically induced. So that can be as a result of ovarian removal for cancer or endometriosis or PMDD, such as a severe form of premenstrual disorder, for example, or could be the fact when ovaries are shut down with medications such as GnRH analogues for similar things like endometriosis or when breast cancer treatment. Menopause, it doesn't just affect the individual, it has wide-reaching impacts in terms of society as well, because it impacts people's their working lives, with 1 in 10 women who go through menopause choosing to leave the workplace because they're struggling with symptoms, having impacts on relationships, both romantic and just in the wider social thing, and also has a huge impact on our healthcare service. This is often because menopausal issues are not picked up or not taken seriously, so people are underdiagnosed. Women struggle with symptoms sometimes for many years. They may be sent off to different specialists. So it wastes time, it's delays in diagnosis and treatment, and obviously that has a knock-on effect with the rest of the healthcare sector as well. So it's in all of our interests to kind of be more aware. Just one example, you could be a cardiologist who's seeing patients with palpitations that actually are, relating to, dips in estrogen as part of a menopausal picture. It's not uncommon to be a rheumatologist and see people for aches and pains that are secondary to estrogen kind of deficiency in POI, for example. So these are things that we kind of need to consider. So first of all, what is POI, or premature ovarian insufficiency? Well, this is the loss of normal, excuse me, ovarian function and hormones below the age of 40. It's now the preferred term for premature menopause or other ovarian dysfunction that occurs below the age of 40. There's been a bit of debate about terminology, but this is the one that we now prefer to use. Often people previously have used premature ovarian failure, but for obvious reasons, insufficiency is a preferred term. So spontaneous POI, so that's POI that occurs that's nothing to do with kind of medical or surgical intervention, is estimated to affect around 3% of the global female or AFAB population, and is thought to be related to problems with the ovarian follicles, which is where the immature eggs or oocytes are found. So those issues may be that there are not enough follicles at birth, or that the follicles are used up more quickly than we would expect, or that there's just a problem with the function of the follicles. The causes are kind of multiple, but unfortunately for most people, we don't know what's led to this diagnosis of POI. So 90% of girls and women with POI have what's termed idiopathic POI, and there's no known cause. But there are genetic associations, so Turner syndrome and Fragile X, for example. There are autoimmune associations, so autoimmune thyroid disorder, adrenal dysfunction, type 1 diabetes, for example. Those women with those diagnoses are more likely to develop POI and vice versa. Certainly in developing parts of the world, infections play a role. Sometimes that can be malaria, TB, mumps, for example, anything that can affect ovarian function. Metabolic disorders such as galactosemia. There appears to be a role of toxins. So this can be environmental toxins. There's new and emerging data suggesting some of the toxins within plastics can affect ovarian function. But we know, for example, that smoking is associated with problems in the ovaries and is associated with an increased risk of a POI diagnosis. And then, of course, there's the cause induced. So if you've been placed in a medical or a surgical menopause as a result of necessary treatment. The one big difference with POI and a more natural menopause later in life, and this obviously only relates to those that not the induced form of menopause, is that ovarian activity can fluctuate. So this can be a kind of changing picture. And not everybody with POI will have stopped their periods completely. And in some cases, spontaneous conception may still occur, and up to around 5%. However, as we'll come to see, most of the issues surrounding menopause, so when periods have finally stopped, do apply to POI, which is why we often lump POI and early menopause together. One of the key messages I want people to take away from this webinar is that no one is too young to be menopausal. So whether you're a healthcare professional or you're somebody who was affected by POI or early menopause, please take this away. I just thought it'd be useful to kind of lay out when it's important to see a doctor, or if you are a healthcare professional, when you should push for a diagnosis, for example. So in young people under the age of 18, if there've been no signs of secondary sexual development, so that's breast development or pubic hair, underarm hair, by the age of 13, or no periods by the age of 15, or no periods within 3 years of developing secondary sexual characteristics, that needs to be looked at. It won't necessarily be POI, but something needs to be addressed and that you need to have further investigation. Similarly, if you're between 18 and 40 and had no or infrequent periods for the last 4 months, and potentially have menopause or estrogen deficiency signs and symptoms, that needs to be looked at. Of course, there can be other conditions that can lead to similar symptoms. But the way that we would diagnose POI is having 2 tests looking particularly at the follicle stimulating hormone, or FSH, on 2 occasions, ideally 4 to 6 weeks apart. And if you or your patient is still menstruating, this should be on day 2 to 5 of the menstrual cycle. If not, it doesn't matter, but it's important to have that gap of at least a month when you're checking levels. To fulfill the diagnosis, the criteria for a diagnosis of POI, the level should be raised consistently on those 2 separate occasions. And frustratingly, it really depends what criteria you're looking at, whether or not you meet the criteria. The ESHRA guidelines, which are European-wide guidelines in terms of managing POI, say that we should we can say that at 20, if the level is over 25. Nice criteria of you want it to be slightly higher. I tend to use the ESHRA criteria, but also looking at the clinical picture. Other investigations and tests are often recommended to investigate the underlying cause. Some of that will depend on the age at which somebody is diagnosed, for example. We don't really have time to go into that here. But if you or your patient is diagnosed with POI, especially in general practice, specialist referral is strongly recommended. Early menopause is menopause where the periods stop between the ages of 40 and 45. It's not the same as perimenopause because this is a permanent state. It's not a fluctuation of the ovarian activity or a dwindling of the ovarian function. This is when your periods have stopped. And we need to address that because that there can be health implications. Spontaneous early menopause occurs in around 12% of the female or AFAB population. And the causes and associations can be similar to POI, but chromosomal abnormalities are less common. For example, it's unlikely something like Turner syndrome or Fragile X is the cause there. There may be genetic components, it may run in families, but it's unlikely we're going to pick up a strict genetic or chromosomal cause. But the rates of induced or iatrogenic early menopause are increasing. Again, diagnostic tests, if you study the ovaries or patient size the ovaries, are important. So you need the consistently raised FSH, the LH or luteinizing hormone to rule out, and consider thyroid function tests as well. Specialist referral review isn't always necessary. So these terms are often used interchangeably, but they're not one and the same, although POI can and often does lead to early menopause, but they're united by 2 fundamental issues: the premature loss of ovarian hormones and the impact this has on quality of life and long-term health. and the impact of reduced fertility and infertility. Okay, so symptoms can be wide-ranging because we have hormone receptors throughout our body. So the typical menopausal symptoms you'll be aware of, so systemic symptoms like vasomotor symptoms, so hot flushes, night sweats, palpitations can be common, although are less common in the younger age group, so in teenagers and women in their early 20s who've had less exposure to estrogen generally. But absent or irregular periods are probably one of the #1 symptoms and signs we need to be looking for. Musculoskeletal symptoms, so aches and pains, dry skin, tinnitus, genitourinary symptoms such as bladder pain or urinary frequency, vaginal dryness, sexual dysfunction, so low libido, GI symptoms, nausea, constipation are common, breast changes, though breast cysts and things can be more common. But there's a huge kind of swathe of emotional and cognitive symptoms, so anxiety, mood swings, low mood, irritability, a poor concentration and brain fog, and low confidence and self-esteem. And this is common in women who go through a natural transition, in their early 50s, but it's particularly so in the younger age group, because this is something that's occurring when you don't expect it. So if you're suddenly told you have POI at 25, and you've obviously associations around menopause can make you feel old before your time, out of step with your peers. And for those of us who are healthcare professionals, it's just really important to kind of be mindful of that. This isn't a kind of benign diagnosis. Yes, it's benign in the sense that it's not usually associated with any form of cancer, unless this has been an iatrogenic induced POI. But it can have wide-ranging impacts on that person's life. And so we need to acknowledge that and recognise that this is a life-changing diagnosis. Equally, a lot of women are diagnosed with early menopause when they're undergoing fertility investigations or infertility investigations. And to be told at 40 that's it, you're through the menopause much earlier than you expected, especially when you're hoping to conceive, it can be particularly devastating. The long-term health impacts are of particular concern in this younger age group. So cardiovascular disease is already increased, and the risk of that goes up for women after menopause, but the risk of heart disease if you have early menopause doubles. This is if it's not managed appropriately. Osteoporosis, there's an increased risk of that. Sarcopenia, so that's kind of muscle wastage. Dementia, Parkinson's disease, insulin resistance, and recurrent urinary tract infections. And these all come about as a result of the drop in estrogen. And this is why we do need to manage this properly. The psychosocial impacts of the self-identity, excuse me, that I've spoken about, infertility, the impact on relationships, particularly if you're diagnosed at a very young age. How do you even broach this with somebody if you're a young woman in your 20s and you're just starting out dating? Education and work for obvious reasons, particularly with some of the cognitive changes that can occur. And there can be cultural kind of impact, especially in certain cultures where POI isn't even recognised as a term or isn't even acknowledged. So in terms of management options, we've got I've highlighted HRT or hormone replacement therapy, as this really is the baseline. Everybody should be offered hormone replacement therapy because these conditions really are ones of true kind of hormone deficiency, much as if you had your thyroid removed or your thyroid wasn't working, you would need replacement thyroid hormones. We need to replace the estrogen. Of course, there are some exceptions. So if somebody has had an estrogen positive breast cancer, and is an estrogen blocking medication or has had their ovaries removed for that reason, that would not be their first line of treatment. But for most women with POI and early menopause, they could be on HRT. So the nutrition and lifestyle things that I'm going to discuss are really to support that. And for those who can't take HRT, really should pay extra attention here, because there are things we can kind of do to kind of improve the outcomes. And the reason I'm particularly interested in this is that I myself had a premature menopause as a result of surgery at the age of 35. And I, for a long time, thought that I just needed to get my HRT right. And that was part of the picture. But it took me quite some time to kind of realise and accept that actually what I did, how I ate, how I moved, how I managed stress had a huge impact. on my symptoms and how well I felt, and actually how well my HRT worked. So quickly, I've told you this would be a little bit of a whistle-stop tour. Nutrition plays a huge role in symptom management in POI and early menopause, but there is no menopause diet per se. However, what we do know from studies, although I have to be honest, a lot of the studies are around women in natural menopause transition, but I think we can extrapolate a lot of that because this is looking really at symptoms that are secondary to kind of estrogen deficiency and fluctuations. What we do know is that a plant predominant dietary pattern is recommended. And at the British Menopause Society conference last year, there was acknowledgement that we really should be recommending at least a 95% plant-based diet to women, all women in menopause, whether that's natural menopause, POI, or early menopause. So there is no kind of, a strict pattern that you would have to follow. I'm not a fan of saying you need to be low carb or high carb or high fat or low fat. It's more the makeup of the diet. So what we really want to do is think about right carbs and good fats. In fact, low fat, very low fat diets are not recommended with this, and neither will be a very low carbohydrate diet for reasons we'll kind of come on to. One of the most important, probably most well-researched areas of nutrition when it comes to menopause are phytoestrogens, and soya is one of the main dietary components here. Soya is a form of isoflavone, which is a type of phytoestrogen, and phytoestrogens essentially are kind of plant-based compounds that act on our estrogen receptors. However, they don't act in exactly the same way as estrogens, excuse me, but they're thought to act more like selective estrogen receptor modulators, or SERMs. So essentially, they're kind of compounds that can have estrogen-like effects in some tissues, so kind of positive effects in terms of bone health and heart health, but they kind of almost have estrogen blocking effects in the uterus and the breast. So they tend to have all the good aspects of estrogen and less of some of the concerning ones. So there have been numerous studies done around soya and observational studies. There have been a couple of kind of randomized controlled trials looking at that, at soya and stuff and menopausal health. And some of the results have been quite mixed. There's been a very good review that was published, I think, in August 2022. Messina is one of the lead authors on that, Mark Messina. And they looked at all of the evidence. And I think because there's been a lot of confusion around the role that soya plays in menopausal health, it's because they haven't really drilled down into the detail. But when we look at the type of isoflavone that is included in some of the soya trials, we can see that if you're having a decent amount of the isoflavone genistein in the soya, I think over 20 milligrams kind of a day, then that makes a big impact in terms of menopausal symptoms. So it reduces the rate of hot flushes and things like that, and can improve general health and well-being. I think we're going to kind of talk a little bit more about soya in the kind of question and answer section, because there's a lot more to kind of get through. But it's safe to say that soya should be something that we could be recommending to patients to include in their diet, because it does have positive effects on the on menopausal symptoms in many ways. Also appears to have very positive effects in terms of gut health, may also have positive effects in bone health, although the evidence there is a little bit mixed. And it is safe to consume if you have a diagnosis of breast cancer. Again, some people, there's been concern in medical circles about this previously, but looking at the recent meta-analysis on this, we don't need to be concerned. And there's even been research showing that it may reduce the risk of recurrence in people with a diagnosis of previous breast cancer. So this is dietary consumption. We're not talking about supplements. There's also the estrobolome, which is an area of emerging interest, which is basically the group of bacteria in the gut that can metabolize estrogens. And this is really fascinating. And basically the estrobolome, so these are healthy bacteria that can kind of break down estrogen byproducts and affect the kind of, I suppose, how you're passing out estrogen breakdown products, via the bowel, or whether you reabsorb and break down estrogen products back into the bloodstream. That might sound like a positive thing if you're reabsorbing, if you're low in estrogen, but actually what it does is it causes fluctuations, and that can be problematic. What's interesting is that women with a plant-based diet tend to have less of the beta-glucuronidase, which is the enzyme which kind of reactivates the estrogen in the gut, and tend to kind of pass out more of the breakdown products, and tend to have a more stable hormonal background, which is helpful in menopause. So and there's also actually some research suggesting that depending on the kind of bacteria you have in your gut, a lot of the healthy bacteria coming from a very rich kind of dietary sources of fiber and stuff like that may even impact how well you kind of respond to HRT or other things, including soya in the diet or soy supplements and things like that. So this is an area we kind of need to watch. Polyphenols, so these are plant-based compounds that are found in lots of plant-based foods, such as kind of dark colored grapes and berries and dark chocolate, for example, things like pomegranate. They can be very helpful in terms of brain health. There was a study looking at nutrition and in menopause and brain health particularly, but also again impacting a type of gut health as well. And it's been shown that if you've got higher levels of these, this can influence the bacteria that can help protect the lining of the bowel and stuff, and reduce kind of gut or intestinal permeability, which is something that is affected in menopause and may be part of the reason that we see an increase in food allergies and intolerances around menopause. We also need to consider eating for kind of long-term health, because obviously there's this increased risk of osteoporosis, heart disease, unfortunately dementia, if we have untreated POI and early menopause. So in terms of bone health, again, a plant predominantly dietary pattern can be beneficial, but we do need to pay particular attention. So Shireen has done a very good review on kind of plant-based diets and bone health, and obviously there's the webinar next month is going to be kind of addressing this as well. Essentially, if you are meeting your calcium requirements and your protein requirements, and supplementing with vitamin D and B12, it's likely that a plant-based diet is actually incredibly beneficial for your bone health. But I think sometimes we don't talk enough about the importance of having adequate protein in terms of bone health. It's particularly in vegans and people who follow a plant-based diet. And really, if you are following a plant-based diet or not, you need to be including at least 1 to 1.2 grams per kilogram of body weight to get adequate protein to manage your bone, to look after your bones at this stage. Also ensuring you're having around 1,000 milligrams of calcium daily in your diet, which can be easily met on a plant-based diet. So with fortified calcium or calcium select tofu, leafy greens, legumes, tahini, there's a wide range of of foods that you can have that will improve your calcium uptake. And that's where vitamin D comes in as well. In terms of heart health, again, we know that a plant-predominantly dietary pattern is inherently anti-inflammatory, and is associated with the reduced risk of cardiovascular disease and reduced, including lower cholesterol levels. That's where soya comes in as well. We want to, if you include things like leafy greens and nitric oxide, rich foods and things like rhubarb and beetroot and things like that, that's good for the endothelial cells, opening up the blood vessels. And what's good for the heart is also good for the brain. We also need to include things like omega-3 fatty acids. So, seeds and things like that can be very helpful. Obviously, if people don't include fish in their diet, it may be worth supplementing with an algae-based supplement. The data is a little bit mixed on that, but that's often kind of what I recommend. Okay. Physical activity, again, is something that's really important. 1, to help manage symptoms, 2, to protect long-term health. So strength and resistance training is at the top here, because this is the main form of exercise that has been shown to benefit women with menopausal symptoms or symptoms of estrogen deficiency. So even if you or your patient can't take HRT, This has been shown to kind of alleviate or reduce the risk of things like hot flushes and vasomotor symptoms in particular, and improve mood, which can be particularly important. So kind of getting women to lift weights 2 to 3 times a week, and building up that muscle, because we get muscle loss with that associated estrogen loss, is something that we really need to explore with our patients, or if you're a patient yourself, you need to consider. Cardiovascular exercise is obviously important for long-term health, although it can be mixed in terms of how you feel, whether it improves your kind of physical symptoms. So if you're somebody who struggles with hot flushes, and then you get all hot and sweaty on a run, that may not be particularly helpful for you, although it has been shown to kind of, reduce the mental health kind of effects that can be felt with menopause and POI. I think the key thing there is kind of, to look at other things that can help manage the hot flushes, whether that is HRT or other supplements or things like CBT, for example, because obviously cardiovascular exercise is incredibly important. So maybe that swimming or something else would be beneficial. Weight-bearing exercise is incredibly important for the bones, and really needs to be prioritised along with the strength and resistance training, which obviously is a form of weight-bearing exercise. So weight-bearing, obviously walking, running, dance, tennis, all of those things. You need to put the force of your body of your whole skeleton needs to go through your feet. So this is where cycling and swimming wouldn't be the #1 exercise, but so it's just important to do that as well. Yoga has been shown with various studies to be beneficial in reducing menopausal symptoms. And we're not entirely sure why that is, but some of it, obviously, it can be a weight-bearing exercise. It helps develop strength as well, and flexibility. But also, I think some of it's the calming effect, depending on the type of yoga that is performed and the effects that has on the autonomic nervous system, decreasing stress, the breathing techniques. But it has been shown to be helpful, particularly in breast cancer patients who can't take HRT. So that's something I think when it's practiced as a whole body exercise is particularly beneficial. And I often recommend yoga with Adrienne, who I'm sure some of you will know, who has a free YouTube channel, and she has lots of free videos and things on there, including for people who aren't able to do very energetic yoga, excuse me, I like wheelchair-based yoga as well. Cold water swimming, just a note here, excuse me. So sorry, is a new thing of late that's being studied by Professor Joyce Harper at UCL. For example, as she's found benefit herself, although she's not in the POI camp, but she's struggled, well, not struggled, but she's menopausal, and she's found this beneficial. A lot of women are now taking to, excuse me, I'm just going to put myself on mute. I don't think I can put myself on mute. Go back. Bear with me. Sorry, the cold water swimming, we're not quite sure if it's the cold water itself that's been helpful for both physical symptoms and the psychological symptoms of menopause and POI, or if it's more to do with being in nature and being with others, but we think it may be a combination of things. Excuse me. Okay, so the next pillar to discuss briefly is minimizing harmful substances. So #1 is no smoking is obviously recommended. As I said earlier, smoking is associated with an increased risk of POI and early menopause because it damages the ovaries. Alcohol is another one, and often I think people fail to address that. A lot of people, whether they're naturally menopausal in their 50s or if they're struggling with POI or early menopause, may start to consume alcohol more regularly to help manage some of the symptoms, whether that's difficulties relating to sleep, or difficulties relating to anxiety, or sometimes it can be as a result of finding that diagnosis difficult to deal with. And it's, in a bit way that people may comfort eat, or, for example, having a glass of wine feels like a treat when everything else feels completely rotten, for example. However, although a small amount of alcohol is not going to be harmful, in moderation, particularly if you have that with food, it is an endocrine disruptor. It can lead to hormonal fluctuations, which can lead to worse menopausal symptoms. And if you have or your patient has a large alcohol intake, that has a negative effect on brain health and cognition, and also bone health, and increasing the risk of things like cardiovascular disease and osteoporosis. I wasn't sure whether to include caffeine in this kind of slide, because I don't consider caffeine a harmful substance per se, but if you have a high caffeine intake, this could be kind of exacerbating some menopausal symptoms, and I think it's important to be kind of mindful of that. So if anxiety or palpitations in particular are problematic, and you have like a high consumption of coffee, or the patient tells you they drink 6 or 7 cups of tea a day, that might be something to address. And the other thing just to say about alcohol, when I said it's an endocrine disruptor, I do see plenty of women in clinic who are on HRT. They may be following a relatively healthy diet, exercising, but they feel that they still can't get quite things right. And often it's the alcohol that is the kind of elephant in the room. And even if they're having, say, a small glass of wine every night with their meal, a lot of people don't like to hear it, but sometimes that's the thing that needs to be removed. And I've seen patients where they take alcohol out, and their hot flushes and other symptoms reduced by 60–70%. So I think that's something that we just can't ignore as clinicians or as patients. I know myself that I can't really tolerate much alcohol, because I certainly have it, I experience menopausal symptoms, whether or not my HRT is at a good level, if I have, say, more than 1 glass of wine. So it's just something that we do need to be aware of and that our patients know about too. Sleep, this is a big one for a lot of people. Sleep is often disrupted for women in menopause, whether this is a POI picture, early menopause, or natural. Sometimes this is related to uncontrolled vasomotor symptoms, so night sweats and palpitations. But this can also occur in women who don't experience those symptoms, and not everybody does experience hot flushes and night sweats. To be honest, around 20% don't. And although this is more of an anecdotal thing, I don't, in my clinic, if somebody doesn't experience hot flushes and vasomotor symptoms, if I ask them about their dietary pattern, they're more often than not, they tend to be plant-based, whether it's vegetarian or vegan. And so I think that's quite interesting. If we look at the studies, that does kind of bear out as well. And I think it may be because of hot flushes are associated with an increased risk of cardiovascular disease. We already know that a plant-based diet reduces your risk of cardiovascular disease. So I think these things kind of go hand in hand. Having said that, you may have no hot flushes, but you could still struggle to sleep, or may fall asleep and wake early. We know that menopause and estrogen deficiency affect the pineal gland, which is responsible for kind of melatonin production, which is that biochemical that makes us, or that hormone that makes us kind of sleepy at bedtime. And so it could be to do with that. So there are some certain lifestyle things that you can do that can improve your response, or your body's response to making that. So exposure to early morning light is important. If you can't get out in the early morning, even just trying to kind of sit by a bright window while you have your breakfast, or having one of those, SAD lamps, or light therapy kind of lamps that you could have at your desk at work potentially. If you're struggling with hot flushes and stuff, because I don't want to give the idea that nobody, that if you have a plant-based diet, you will never experience hot flushes, because there certainly are some women who do, and some of this will be genetically driven. And it's not that you're not, doing things right, for example. You try things like wearing natural fibers, so cotton, for example, or even just sleeping naked. Avoiding stimulants, particularly in the afternoon and evening. So that's the caffeine, particularly drinking alcohol before bed. Nicotine, again, that can affect sleep as well. Some women find benefit with a weighted blanket. Again, though, if you're struggling with hot sweats, that may not be the best thing. But if you're one of those people without hot sweats, or your patient doesn't have hot sweats, this could be something to suggest. But the best evidence we have actually for managing sleep disturbance in menopause overall is actually cognitive behavioral therapy, when it's targeted for insomnia. And there are 2 kind of group things that I recommend. Some of them are commissioned on the NHS. There's 2 group programs. There's Sleep Station and there's Sleepio, which are worth looking at. mindful of the time, but obviously we need to look at the mental well-being, because stress has a huge impact on how we or our patients experience menopausal or POI symptoms. So I've touched on a few things, like mentioned yoga and breath work, that can be incredibly helpful in terms of managing stress, meditation, but having some kind of nature therapy, doing things like gardening. With the more we're learning about a kind of nature and how this affects our psyche and stuff, it's really fascinating. We haven't got time to go in here, but all of these things will help. Journaling, writing a gratitude journal, you know, anything that helps manage your stress is worth kind of your time, and trying to find that time for yourself. As I said, like cortisol, the stress hormone that is produced, that can affect the actions of estrogen. So whether it's your own or you're taking HRT, and it can block the actions of estrogen. So if we can minimize our stress load, that we can free up any estrogen that our body has to kind of do its thing. Social connection is very important, and particularly so in POI and early menopause. We, as I say, although menopause awareness is growing, which is great, often people with POI and early menopause are left out the equation. The DAISY Network is the charity in the UK that focuses on patients with a diagnosis of POI, and they have like an active Facebook group. They also kind of do run webinars, and they have a monthly kind of online chat where if you're a member, you can kind of join free of charge and ask anonymous questions and be directed to further support. And there are DAISY doctors on there. I used to do kind of some of the sessions, and so the medical doctors who go on there to give advice. There are menopause cafes that are springing up all around the UK. You can just Google that, and there are younger women who go to those. And virtual group consultations, these are being rolled out on the NHS, and Plant-Based Health Online also run these, and we're kind of setting up a menopause one, which does include those with POI and early menopause, should they wish. Passions and purpose, finally. This is one of the key things that is incredibly important. Don't let a diagnosis of POI define you or define your patients. Finding a high purpose is always important. So whether that is, you know, around work or kind of volunteering, or maybe it's finding, you know, a hobby. Maybe you've always wanted to learn a particular instrument, for example. Anything that kind of gives you a sense of well-being and or I don't know, lights your fire. Follow those things. We should be encouraging our patients to do that as well. Finally, just a very quick slide on diversity, inclusion and sustainability. There's not enough time to go through all of these things, but everything listed here is really relevant in the menopause space as a whole, but also in POI and early menopause. So socioeconomic inequalities are hugely important, and particularly at the moment in the UK, in terms of access to information, accessing good care, because a lot of women will seek out private care, but obviously I'm not saying that private care is necessarily better than the NHS. It isn't. It's just a lot of patients are waiting such a long time to see a specialist on the NHS, that they're seeking private care, but obviously that's not possible for a lot of people. A lot of recommendations you see from wellness gurus and things like that are out of reach for people if they don't have a good income. So there are those inequalities. Even purchasing things like the book or books on the topic can be a problem, and that's where we need to kind of, I don't know, champion libraries and things like that. Race and ethnicity are very relevant. You know, Black women, for example, are much more likely to have their ovaries removed at a younger age, and less likely to be offered HRT. In some parts of India, where, you know, we see much higher rates of POI, and this could be due to people who are living in highly polluted areas. So it may be more an environmental thing because of air pollution and ovarian dysfunction. But we also know that people who are born in a lower caste or on poverty in rural India are much more likely again to undergo hysterectomy and ovary removal, and they're not. A lot of these girls and young women are not given the advice that they need to help manage their health in terms of the estrogen deficiency going forward. And the LGBT community are often left out of the conversation, and yet anybody who is born or assigned female at birth and goes on to transition to become transmasculine will go through an early menopause if they choose to have gender affirming treatment. And again, they're left out of the equation. Disability is important. Women with learning disabilities are more likely to experience early menopause, particularly if they also have a concomitant diagnosis of epilepsy, which is associated with an early menopause, and therefore an increased risk of fracture because of the epilepsy drugs and falling. So all of these things are connected. Neurodiversity, ADHD, autism spectrum. The women who come under that umbrella tend to experience more hormone sensitivity, more likely to have problematic symptoms, and often these things may not be picked up. HIV is associated, if it's not treated well or picked up, with increased risk of developing early menopause. But I think women with HIV, often a lot of their symptoms, if they are having menopausal symptoms, are put down to kind of side effects of HRV medication, and the whole side of menopause may be overlooked. And then we've got the whole issue of sustainable prescribing, which we don't have time to go into here, but maybe we can touch on in the Q&A. Just finally, some further information resources. Obviously, plant-based health professionals at the top with all their fact sheets if people don't know where to start in terms of plant-based diets. But here we've got the ESHRA guidelines on POI and some other things for health professionals as well. Just really wanted to draw attention to the menopause group programs or virtual group consultations that I'm going to be running with Plant-Based Health Online. If you want any more information, if you can sign up for those. We don't have the email address on here, I've just realised, but I can ask Rahini to send that out. And this is just the book that I wrote together with my friend and colleague Mandy, who's a GP specialist like me. This is available to buy wherever you buy books, but it's also available in libraries, so you don't have to purchase it if it's not possible. And we've had good feedback, so I hope it's useful to people. References, there are too many really to mention, so I've basically started with the white paper on POI, which was published in 2020. We've got extensive references for all things POIs, particularly related to lifestyle and everything, on my website under the references, and here's the link. Thank you. And I'm sorry, I think I've overrun.
No, that was brilliant. Thank you.
Sorry. I'm sorry for the coughing.
It's okay, I think it's coughing season. So I will crack on with the Q&A. I think you covered so much in that, but as expected, there are always soya questions that come up in a webinar like this. And the question is, can all women consume soya products providing they aren't allergic, regardless of if they've had breast cancer and are unable to take HRT?
Yes, so the latest research, we're looking at the summary of the research, is that dietary soya is safe to consume. I think it's hard to say we've got enough to recommend to say you should absolutely must consume it to reduce your risk of breast cancer recurrence. But if anything, the studies are hugely encouraging and have shown an association with a reduced risk of breast cancer, particularly in those who've had breast cancer previously. So yes, it's dietary consumption is recommended. There's no good association with progression of cancer or kind of increasing your risk. Like I say, it's the other. So if you're not allergic, there's no reason to avoid it. We need to be a bit more cautious when it comes to supplements, because they're a bit more like pharmaceutical medications, and they're extracting all the other good things that come with the whole soya food. But yeah, and that's something that just needs to be explored. So, but yes, it's safe to consume, and there's the good. In fact, I might send this paper to Rahini because I don't know if it's on my list because it hadn't come out when we published the book about the soya summary that talks about that. But there is a reference in the references from our book as well.
Perfect. And just to emphasize as well that very few people are actually allergic to soya. I think the statistics are something like 0.3% of the white European population have an actual allergy to soya, whereas obviously for lactose intolerance or malabsorption, it's over 70% globally. In some races, it's even higher than that. So when we're talking about soya, we're talking about more of the minimally processed forms of soya, things like edamame beans, tofu, tempeh, soy milk, soy yogurt, rather than soya burgers or soy protein, which might be an occasional food, but not an everyday food that's going to bring about health. And there's another question as well about an alternatives to HRT. So it's someone's sharing their personal experience saying, for those women with a history of breast cancer, is there no alternative to HRT? I personally have been very lucky. I eat loads of soya and I barely suffer with anything, but what could I do if I did?
So, well, there are medical alternatives, and I think it depends if we're kind of thinking about, you know, medical alternatives. So things like the SSRIs can be helpful in terms of hot flushes or migraines, things like that. It depends if pain is a problem. Sometimes some of the previous drugs that have been used for anti-epilepsy medication, so pregabalin and gabapentin, but they can be quite hardcore. But again, with all of these things, it depends on the risks versus the benefits, and so that would be done on an individual basis. In terms of what else can you do, there's some good evidence for cognitive behavioural therapy, and we think this may be how it affects the autonomic nervous system, but I think some people assume when you talk about CBT that you're just telling people not to be so stressed, but it's a bit more complex than that. We said that there are studies showing that it does reduce the rate of hot intensity of things like hot flushes and night sweats. Also, yoga has been shown to be beneficial in terms of the musculoskeletal system, and in terms of hot flushes, in terms of anxiety and low mood and depression. If vaginal symptoms are a problem or dry eyes, things like taking the sea buckthorn oil as a supplement or including that can be quite helpful, and making sure you have enough of the omega-3 fatty acids in your diets and good healthy plant-based fats. So, you know, whether it's kind of olive oil or nuts and seeds and things like that, really making sure you're including those. A good source of vitamin E in the diet, but it really depends on kind of the individual things that are helping. I think I mentioned in the exercise section, the best evidence we have in terms of managing symptoms is the resistance training, and it's because the muscles, as you kind of develop muscle strength, release myokines, which are hormone-like chemicals that have profound effects on the neurotransmitters in the brain, and can almost act like hormones as well. I mean, there's multiple kind of herbal supplements out there, but you have to be a little bit cautious in knowing if you're getting a good quality supplement, so I on an individual basis I could kind of like advise depending on that, but it's difficult in a general thing like that. We discuss it in the book, but also the British Menopause Society, they have a whole leaflet, so there's a link in that at the end. You can go through to there. They've got things on all the alternatives, and there's also Women's Health Concern provide information on that too. So there are always things you can do, but unfortunately, because there's no a drug that's alternative to estrogen that does all the things estrogen does, it tends to be more symptom driven. And if it's more of a concern about osteoporosis, it would be more focus on the bone health side of things. So
wonderful. No, I completely agree with that. The brain protective benefits as well of resistance training, and also managing a healthy weight, because that can be a challenge for people experiencing menopause and early age, although exercise, we know, isn't the best way of encouraging weight loss. It's more for weight maintenance and general health and well-being. So yeah, you dive into that in more detail in the book. And similarly with the supplements, I think that anyone going through the menopause is bombarded with so many different supplements that are out there, and they don't all come they all have a certain safety profile that has to be considered, and then pros and cons. I think you talk in the book about magnesium citrate, that the most evidence is for that, but that of course it does cause diarrhea for some people, so it all has to be weighed up and things. Someone here has shared their personal experience, said that they are going through early perimenopause, age 39. HRT has been fantastic for them. They've responded very positively to progesterone, and they've read that progesterone is the main symptom driver in early perimenopause. Is there a dietary addition that complements progesterone? There seems to be more advice regarding estrogen.
So it's not something really that I think has been fully investigated. So In terms of progesterone, I don't know if I understood the question particularly. So the progesterone, so it's often the lack of progesterone can sometimes dry. Is that, I think that's that what they're saying?
Yeah,
So
that's what they're saying.
the lack of progesterone, because if you're not ovulating, you're not going to produce the progesterone. So if you're going through and you're having anovulatory cycles, then that can that can be causing some of the symptoms in some women, and they kind of almost need that to kind of balance the estrogen. It really depends on your kind of your genetic makeup, your hormone sensitivity, because some women are so lucky and don't experience any symptoms at all. I mean, the progesterone that I often prescribe in my clinic is derived from a wild yam. So yes, the wild yams and the phytoestrogens have probably similar kind of effects in that sense. But I don't know, unless you, obviously you're a nutritionist, Rahini, I don't know if you've learned more about that, but it's not something we tend to discuss or I know much about, because
exactly what you say in your book, like it's very easy to hyperfixate on specific foods, but the truth is it's that overall healthful dietary pattern that is rich in whole foods that's going to benefit you. And as you mentioned, there are certain, rather than fixating on macronutrients, although I do think plant protein should be emphasized in this phase of life, and you can easily do that by including a sauce at every meal or with a snack and things. So soy milk for breakfast, tofu or lentil curries, just being conscious in those ways, and that's going to also be more satiating as well. I generally suggest that rather than trying to eat one specific thing. So I know that there's studies showing that watermelon can help with vaginal lubrication and things, but I wouldn't suggest someone just eats watermelon. I would suggest having all different fruits, and obviously if you want to add in watermelon symptoms, that's great, but I think it could get quite stressful if you're just trying to optimize by eating just one specific fruit.
Well, it's a bit like when people talk about things like seed cycling for kind of premenstrual disorders, and we don't have any good evidence really kind of for that, or just generally throughout the menstrual cycle. It's just better to eat, I don't know, eat the rainbow, eat the alphabet, a wide variety of plant-based foods, and making sure that you do include, nuts and seeds and wide variety of different legumes and things like that, and brightly coloured vegetables, different forms of plant-based protein in your diet.
Yeah, I totally agree. And then there are some that maybe have more processing, things like legume-based pastas, like pea pasta or edamame bean pasta and things that can be really helpful when you're busy, and maybe sometimes your appetite could be reduced as well as you get older. So that's a good way of getting in more protein, and blending silken tofu into sauces or smoothies and things like that. There's loads of different tips and things out there. I suppose what I really enjoyed in the book is that you focus on a lot of the mental health aspects as well associated with POI and early menopause, which often don't get talked about, or there isn't time often, in a doctor's appointment. And you've got a chapter, menopause, I think it's from your head to your toes, and things. What can we do as health professionals to get this message out there? Because so often the depictions of menopause show sort of steel-colored haired ladies in their 60s, and young women who may be going through the menopause or POI may not be feeling represented in those images. What can we do as health professionals to offer more support, and also just raise awareness of the fact that this does affect up to 4 in 100 women, and people assigned female at birth?
Well, I guess we just need to keep talking about it. So it's great that you wanted to put this on the webinar, because I think there are still some healthcare professionals who don't even realise, or it doesn't focus, at least when I was at medical school, we didn't really get training in this. And so I think it's talking. It is one of the main things. Raising awareness. I think we need to change. I suppose just kind of get the message out there that menopause can happen at any age. It is difficult because some women with POI don't like the term menopause, because POI was, POI is subtly different to menopause. But we have to, I think if we want to get the message out there, we need to kind of have quite black and white messaging that menopause, whether it's POI, early menopause or perimenopause, can happen at any age. And I think it's and just change, I suppose, when we have these awareness campaigns, there should always be a representative from the younger community. I mean, there's so many women who go through an iatrogenic menopause at a younger age, under 45. And I mean, the 12% estimate for early menopause is for spontaneous early menopause. It's not including the women. And lots of women who have, say, a prophylactic oophorectomy, so their ovaries removed to reduce the risk of ovarian cancer. That's huge. It was a huge number, really, when you're going up into the 40s to 50s. That's the main age time they would tell you to do that to reduce your risk. So I mean, old oncologists need to be talking about this. Endocrinologists, we need to be looking at it. Gynecologists. I think we all just need to talk to each other a bit more. We need to have better teaching, but I don't really know what to do other than kind of raising awareness on things like social media, doing things like this. That's why we wrote the book, because we felt that it was just a little bit of a, it's a bit of a side chapter or, small print at the end. Though this can affect a small group of women, it's actually not that insignificant though, is it? It's, it's quite a lot of women who are affected. Yeah, so I don't know, that wasn't for a particularly helpful answer, because I think we just need to keep talking.
And the book also
information.
Yeah, and you also mentioned in the book, as you said, all the different reasons why someone could have gone through early menopause, which of course is distinct to POI, but things like cancer treatment and a variety of other issues. So it's not just one specific one sole reason. I guess it's just thinking of how we can all work together. And I guess everyone who's going through this does need that multidisciplinary team of different health professionals working together to support the person from the mental and physical health aspects, obviously managing them if they're on medications, and looking at their long-term health as well, and increased risk of other conditions. So as you said, endocrinology, oncology, gynecology, maybe dermatology, it's probably literally touches every single aspect.
I think this is it. And this is what I was saying with the societal impact. It does have a huge impact, like menopause does generally. Take even what POI and early menopause aside, there are so many wasted referrals and misdiagnoses, and women, much like they are with endometriosis, PMS, PMDD, PCOS, wait years for diagnoses sometimes, or are missed altogether. And I don't know. I think just as healthcare professionals, it just needs to be on our radar. We need to consider it. I still see women. I saw somebody last week who said to me that, my period stopped when I was 24, but I was just told I was too young and I must just be a bit stressed. And I was left. And this is like nearly 10 years ago for her. And you think you've wasted 10 years that her bone health would have suffered, her heart health may have suffered, the stress and the fact that she's felt dismissed and stuff. So, and I think if we do give that diagnosis, we just need to be mindful it's not the same as saying to somebody at 51, oh yes, you're now menopausal. It's very, very different. And even me, when I knew I was going to enter menopause when I had my ovaries removed, I understood that. Was not prepared for the impact that had. I wasn't prepared for how severe the symptoms could be. But I think it was more the emotional fallout and not realizing that actually you do feel quite different to your peer group. And so everybody around me, I went to medical school relatively late, but everybody around me was having children. And I'm not saying I'm lucky in that I was never desperate to become a mother, but I hadn't really decided, but I was kind of forced into a situation where I couldn't have children. I had to make that decision because I had no quality of life. And you find that you're excluded from stuff because people don't want to invite you because they're worried you're going to be upset, or they just don't think to invite you because you don't have kids. So I think it's that thing that these are the difficult things. So
yeah, I think you deal with that so sensitively in the fertility chapter in the book, and also signposting to resources like Gateway Women and organizations like that, which are so helpful. And also, just to end on a hopeful note, I really like that you touched on, clearly we need way more research into POI and early menopause, and far more research into all these areas in general, but that there are new developments taking place, things like ovarian biopsies and scratch, and various methods that might help women who wish to conceive and have POI or early menopause to use their eggs or extend the fertile kind of timeline. So I thought that there was some really nice things in your book that were kind of just showing that hopefully there's some promise or some hope of more research in these areas. And just generally it's raising awareness and changing society's expectations of what a woman should be or what a woman's natural role is, and all of these things. yeah, we need to highlight. So on that note, I think we'll wrap up, and it's such a great webinar to have on International Women's Day. And if you enjoyed this, please do consider joining PVHP as a member or signing up for our future webinars. And obviously, I can't recommend Hannah's book enough. It really is such a fantastic read. I'm holding it upside down. Such a fantastic read. And even if you're not personally affected by POI or early menopause, just to understand that and give support to other people in your life, to your patients. And also there's so many amazing lifestyle tips in it that I think all of us could benefit from. So thank you everyone, and good night. And thank you so much, Hannah. A brilliant webinar.